Hello and welcome to Module 2 of Unity Hospice's volunteer training. In today's module, we're going to be covering dying, death, grief, and bereavement. My name is Roman Archer. I'm the chaplain and director of patient services at Unity Hospice. I'll be taking you through Module 2 today. There is a brief bio and a photo of myself on the screen you can take a look at. Get to know me if you'd like, and we will continue on when you're ready. To start Module 2, we have another quote. This one is from Earl Grolman. It says, "Grief is not a disorder, a disease, or a sign of weakness. It is an emotional, physical, and spiritual necessity. It is the price you pay for love. The only cure for grief is to grieve." In this module, we'll be covering the common fears people carry surrounding death. We're going to talk about the stages of dying. We're going to talk about the time of death and your role as volunteer. And we're going to talk about the stages of grief. To kick off the Module 2 content, we've got a video resource for you. It's called "Why Thinking About Death Helps You Live a Better Life." This is from Alua Arthur. She is a death doula and has written a book, Perfectly Briefly Human, a book that I highly recommend. In this TED Talk, she's going to set the tone for today as we deal with some pretty heavy topics. So I invite you to access this resource by pausing this video and using the link that is found in your Module 2 handout. All right, throughout this training, you're going to encounter several contemplation and journal slides. We encourage you to pause the video when you reach one of these slides and take the time to reflect on what you've learned and any feelings that arise. Being a good hospice volunteer involves being in touch with your own emotions so that we can empathize with others. The first journal prompt asks us to take a minute and think what it might be like to live with a serious illness. What would change for you? What would become most important to you? What would be most difficult for you? Would there be any positive at all in it? Take a moment to consider some of these things, what it might be like if you were personally in that situation. Remember, when it's personal, it's more impactful. So please pause the video now, reflect on these questions, and when you are ready, we will continue on. Barriers for people thinking about hospice services. For many people, choosing to go on hospice services or having that conversation with a loved one about hospice services can be a pretty anxious thing to do. So some of the barriers for people thinking about hospice services, to recognize them. Number one, feeling like hospice means giving up all hope for more time with loved ones. This belief causes many people to feel scared about hospice. Even the word hospice can evoke some pretty strong emotions. A lot of people think that hospice is a place where people go and wait to die. That's not the case. Hospice, we do not do anything to hasten nor postpone death. Okay, many people feel like a hospice admission will somehow speed things up. That is not the case. It is important that people have the opportunity to talk through their concerns with someone who is knowledgeable about hospice. Okay, so a lot of people feel like they may be leaving time on the table if they enact their hospice benefits. Another one is feeling like they may have to stop medications or treatments that may give them more time. There is so much that hospice can do to assist people to have their best possible experience with whatever time they have left. Okay, hospice is about doing so much more with time that they have left. And another one is just fearing death. The fear of death can be paralyzing for many people, and so they'll freeze up. They don't know what to do. Questions such as, will it be painful? Will I suffocate? Will I starve to death? Where will I go when I die? Again, death is not something that is comfortable for a lot of people to interface with, so we tend to push it to the margins of our of our own minds, the margins of society. And so a lot of people don't have a lot of experience in this realm. And so they carry a lot of fear, a lot of anxiety, a lot of misconceptions when it comes to fears about death. And that's exactly what we're going to talk about. There's certainly a lot of fear surrounding death and dying for people. But what we typically see is five common fears or scenarios that people are anxious about. And some of them are misconceptions, some of them are half-truths, and some of them are things that we just need to get comfortable with and accepting. So 5 common fears of death. The first one is the finality of life. This is a fear of death. Death signifies the end of life, at least as we know it, as we experience it. And obviously this can create a fear of leaving things undone, of unfinished business, of regrets, of relationships that we wish were different. People may also fear the loss of identity and purpose that comes with the finality of death. And so hospice provides an opportunity for patients to reflect on their life. We call this life review, processing things. It helps them achieve a sense of closure as well. By addressing unresolved personal matters and creating a legacy, hospice helps individuals find peace in their final days. Another common fear is about what happens after death. Uncertainty about what lies beyond death. It's a significant source of fear. It really is, especially for those without a strong spiritual or religious beliefs. But even for those that would say they're agnostic, atheist, there's a lot of fear and anxiety about just what happens, the uncertainty after death. Regardless of religious or spiritual beliefs, hospice care provides emotional and spiritual support through chaplaincy, counseling, and open discussions about beliefs. So even meetings with the chaplain, when we say spiritual worlds, we're really just talking about the meaning making that we make, the interior world of people's lives. A chaplain can step in and help navigate and create some orienting for those conversations. So hospice staff respects all belief systems or the absence of belief systems and helps patients explore their feelings about the afterlife in a safe and comforting space. So fear is what happens after death. Again, not able to provide answers to some of these fears, but we create spaces where we can process and put a name to some of those feelings. The third fear for people is what happens to my body. Many people fear what will happen to their body after they die, worrying about either physical decay or even loss of dignity. So hospice helps patients and families by discussing funeral arrangements, things that need to be taken care of after death, and helping plan for after-death care. By taking these practical concerns and handling the body with care and respect, hospice can ensure dignity even after death. And so these are conversations that we are having once someone is on hospice, helping them process and hopefully quell some of those anxieties. Another one is what happens to my loved ones. Patients often worry about how their death will affect their loved ones, and that's a very, very common and normal thing. How will their family cope emotionally? Will they be financially stable? There's a lot of stressors that come, rising medical costs at end of life. And so a lot of people are worried about what happens to their loved ones. Hospice works very hard to address this by providing family support services such as grief counseling, social work assistance. Every hospice is going to have at least one social worker that can help them navigate some of those waters when it comes to financial questions, wills, all sorts of family support systems. It's going to guide them through the process. It's going to offer reassurance and give them security that they won't be traveling this alone. Either before, during, or after their passing, there are resources and support available. Another fear is, will I miss my loved ones? The fear of being separated from loved ones after death is rooted in the unknown. It's that mystery of what remains of our consciousness. And so hospice care provides emotional support, allowing patients, their loved ones, their support network, their family, to strengthen their connections in whatever time they have remaining. Can maybe bring some closure, some reconciliation, some things that need to be said. We talk a lot about I love you, I'm sorry, thank you. Those are all really important things that at end of life need to be communicated. Hospice also facilitates meaningful final moments that can help bring that closure and ease that fear of separation. So there are many common fears of death. However, those are the 5 that we normally see played out the most, kind of categorized together. Other common concerns that we see at end of life, pain. People are afraid of long periods of pain and or a drawn out illness. Indignity, so disfigurement, embarrassing circumstances. For many people, loss of independence is a very, very hard thing to process and to deal with. And then there's fears not specifically related to the physical body. There's suffering, which is different than physical pain. It could be psychological, emotional, social, and spiritual dimensions of pain. And then, as we briefly touched on, there's the fear of being a burden, financially or physically, to their loved ones. So in summary, the 3 most common fears, if we were to categorize them, would be pain, abandonment for either themselves or their loved ones, or loss of control. Okay, so here's a journaling exercise. We've just reviewed the common fears of death. Many people believe the best way to be with people who are dying is to first confront and address our own fears and concerns. So, what are your fears or concerns regarding death? What thoughts or feelings arose for you as you read this material? Sit with those questions. Sit with the feelings that arise from that. Think about your life, your passing, or the passing of someone that you loved if they were to receive a diagnosis of terminal illness. What fears would come up? What would hold you back from maybe reaching out for assistance? Please pause the video now, reflect on this, and when you are ready, we will continue together. A couple common questions that hospice workers are commonly asked. Number 1, the big one usually is, when will my loved one pass, right? Or when will death occur? When should I fly home to be with dad? Can you give us a timeline? Those are all different iterations of really the same question. It's a difficult question. We can provide guidance. However, predicting the exact moment is not always possible. And so instead of focusing on the timeline, we encourage families to make the most of the time they have, cherish the moments with their loved one. But with that being said, there are some general stages a patient may experience when approaching death, and we're going to cover some of those. So kind of the stages of dying, some of the signs that we see that clue us in on where someone might be at in their end-of-life journey. I do just want to reiterate again, though, that as we go through this, it is not an exact science. As you spend more and more time in hospice, you'll come across this question, and you'll even feel an urgency in your own heart to provide answers for people as far as how much longer they're going to have to wait, how much longer they have with their loved one. And it's a difficult question that we cannot answer. Okay, let's talk about DNRs, which stands for do not resuscitate. Do not resuscitate. Without a DNR, a healthcare provider is going to take action to revive a person who is unconscious or whose heart or breathing has stopped. Okay, so a DNR means that that person does not want any life-saving measures. It means do not resuscitate. Resuscitation means to revive or bring back to life. And so common resuscitation methods include things like CPR, you've seen that, chest compressions, intubation, cardioversion, used to correct abnormal heart rhythms. This is often common. You see the set of paddles to deliver an electric shock to the heart, or it could be done via medication as well. So for a patient in cardiac or respiratory arrest, a DNR simply means that none of these tactics will be used. Now, in hospice, a do not resuscitate order is highly encouraged, especially within our population of older adults. And this is an important consideration to make in the planning of end-of-life care. Choosing a DNR allows patients to pass naturally and peacefully without unnecessary interventions. The sad reality really is that CPR performance, especially on someone that's already terminally ill, it often results really in just unnecessary trauma for the patient and for their loved ones. When we say trauma, both physically, a lot of times ribs can be broken. There's complications that come with that. It can also be a traumatic event for loved ones to watch. There was some medical research that was done and was reviewed on 113 studies on the use of CPR in hospitals, conducted over a 33-year period of time. They found that in 26,000 patients who received resuscitation attempts, only about 3,900 or 15% survived. And when they boiled that same research down into nursing homes, the research indicated that basically between 0 to 2% of the patients receiving resuscitation attempts survive. So you're looking at, for those that are in like an assisted living facility or nursing home, usually there's already some sort of comorbidity. Best case scenario, 2% survive. So we really encourage for those that are looking at end-of-life care to think about a do not resuscitate, the pros and cons of that, especially if their loved one is a little bit older. In hospice care, it's important for us to recognize that dying is not considered a medical emergency. So we're really building off of this idea of the do not resuscitate, the DNRs that we just talked about. In hospice, we understand that death is the natural part of life. It's not a medical emergency. And so in hospice, our focus is more on ensuring the comfort and the quality of life for our patients. And so we're going to do that. We're going to be working to provide a peaceful and dignified end-of-life experience. And this approach helps us to reduce the stress that is often associated with medical emergencies. And this is for both the patient and for their loved ones to feel more at ease. And so this really comes down to an idea of care and presence. We want to create a more meaningful journey. And so we recognize that when you are on hospice, death is not a medical emergency. It's really the outcome that we're building towards. We know it's coming, and we're providing really dignified, comfortable care up until that point. We're going to take a few minutes now. We're going to talk about the 3 stages of dying. Again, there are some signs and some things that clue us in when a patient is journeying through their end of life. There tends to be a bit of a process to it. And so it's not an exact science. We cannot predict when someone is going to pass. But there are clues along the way that help us break it down into stages. We look at them as early transition, and then actively dying. In the next few slides, we're going to take a look at each one a little bit more in depth. So we're going to talk about some of the stages of dying, some of the signs that kind of cue us into where someone is in the process of their end-of-life journey. The first one that we're going to look at is what we call early transition, and it comes with some different things that we're looking for. Number one is going to come with withdrawal. The patient kind of begins to turn inward. We believe that there's maybe some internal work that needs to be done there. The normal things that would maybe bring joy in the past, there's not as much interest in those things. There's a little bit more of withdrawal. Oftentimes there's increased confusion. There's decreased intake of food and water, which I'll talk about in just a second. There's an increase in sleeping. Again, that goes alongside with withdrawal. And we can see an uptick in just generalized pain, body aches, all sorts of things. And so more comfort measures and medications may come into play here. One of the things I do want to talk about is that noticeable drop in the interest in food. We talk about the decreased intake of food and water. For many patients, eating becomes more of a burden than a joy at this point. So again, kind of that withdrawal, that turning inward begins to happen, and the intake of food and water, it's not bringing as much satisfaction as it did. On top of that, there may be an occasional choking on their fluids. They'll start to feel full rather quickly. And what's happening is the body is beginning to conserve energy and doesn't need as much nourishment as it did in the past. And so for loved ones, this can be really troubling to witness. It's important to know, though, that it does not cause any pain or suffering. It's a natural process as the body begins to shut down. Um, we really like to say that the body knows what it's doing, the body knows how to die, and so we follow the cues of the body. For a loved one, it's difficult because we see food and water as nourishment, and we feel like you need to be eating, you need to be drinking, but it's really important to not force this. Even artificial feeding at this point, it is not going to prevent death. If anything, it could lead to some physical distress if we force it. So we follow the cues of the individual with this one. But in early transition, that is one of the things that we see, and it can be troubling for loved ones. To provide comfort, we do encourage that maybe they find foods that were especially special, that carry meaning or memory. And it's less about the nourishment at this point, and it could be used for connection, sips of fluid, ice chips. Ultimately, it's important to just remember that we're respecting the patient's wishes, we're trusting that the body knows what it's doing, and we ensure that there's no pain, we're not hastening death. It's just a natural process that's happening. The next stage that we look for is transition. This is the middle stage of dying, and it's marked by changes in the patient's physical appearance. So there are some physical cues that we're looking for, and it could last a few hours or several days. Some of the symptoms, signs that you're going to see all of the things that we just talked about from early transition, the withdrawal, kind of turning inward, less food and fluid intake, sleepiness, maybe an uptick in generalized pain. But there's also an increased risk of aspiration. So that's choking. That's why the food and fluid intake we're careful of. There could be an increase in incontinence, a decrease in bodily function. There's hallucinations as well. The person is going to become increasingly less responsive to their exterior surroundings and those around them, their environment around them, to eventually where they'll become nonverbal, unable to speak or maybe move. This is typically seen at the very last days of life. As the body's circulation slows down, so the body's beginning to slow down, conserve energy, blood is reserved for helping the major internal organs function, the things that we can't see. So with that, the patient's hands and feet might feel cold. They could even become darker in appearance. During this stage, we would encourage loved ones to offer blankets to increase comfort as the patient's circulation changes. Things like heating pads, electric blankets, we don't generally encourage because, again, the patient's unable to judge if they're becoming too hot. We don't want to burn them or anything like that. The detachment from their surroundings and relationships is the body's physical and spiritual response to the process of dying. It's completely normal. So again, loved ones should assume the patient can hear everything that they say. We say that hearing is the last thing to go. Experts suggest that speaking softly to the patient, touching them, always acknowledging them. It's a way that we show dignity as well. Touching them gently, only if they normally would like to have been touched. This is a good time for prayer, for meditation, for soft speaking. It's not generally recommended to ask the patient questions that are going to require answers, though. And so that is some of the changes that we see in the transition phase. And during the final stage, we call this actively dying. Disorientation, restlessness will grow. This can be a difficult stage for loved ones to watch. Every situation is different, though, but there are some things to keep in mind. You're going to have all of the same things, again, as people are progressing from transition, early transition, to actively dying. You're going to have all of those same things with an addition of other things. There's going to be disorientation, restlessness is going to grow. And the more difficult things is there's going to be changes in the patient's breathing incontinence, okay? So the patient's bowel movements may stop entirely. They may become incontinent. And their breathing is going to become shallow and irregular. There's going to be long pauses, grow frequently as death approaches. It can be difficult to listen to. We ensure to loved ones and families that at this stage, as long as the patient is correctly palliated, with comfort measures and comfort medications. They are perfectly comfortable. It is uncomfortable for us to hear if you're not used to hearing it. But in general, the patient is not aware, and it's actually a sign to us that they are well palliated and comfortable when we hear some of these noises. There's sounds of chest congestion. We also call it like a throat rattle as well. That's a buildup of fluid in the back of the throat. As the patient is unable to swallow, that begins to build up. So it's an unpleasant, uncomfortable sound. But again, to us, it's signifying that they are completely comfortable. The restlessness noted in this stage is attributed to changes in metabolism. The kidneys and bowel functions are affected by decreasing circulation, and so that is causing changes. Relaxing of the muscles, again, that's leading to the incontinence. The slowing of the blood circulation to the internal organs cause the lungs to lose the power to clear out fluids. And some of those throat muscles, again, are just completely relaxed. At this stage, it's helpful for loved ones to continue to talk to their loved ones reassuringly. They are loved, they are safe. Gentle touch is acceptable if the patient liked being touched. Even when they are not responsive, the patient might be able to hear those around them. So it's important to speak respectfully. And just keep in mind, this can be a distressing time for loved ones, and it's best to stay calm. It is unusual, but some patients may need medication for restlessness. Other interventions, maybe a diaper, a catheter, underbody pads may all be utilized. In general, when we hear this throat rattle, that uncomfortable noise, administering oxygen will not help, as the patient doesn't have the capacity to get that oxygen into their bloodstream as circulation is shutting down. So again, as uncomfortable as it is, it's not useful. Elevating the head may help. Turning the patient on their side also can help. And the important thing to remember is it's more uncomfortable for the loved ones and for those to hear than it is for the patient. Okay, let's take a moment and watch a video that kind of breaks down some of the signs of approaching death that we just talked about. To access this resource, you're going to find a link in your Module 2 handout, so you can pause this video and go access it there. It's a short video, but it is illustrated and very informative. So please take a few minutes and head over to your Module 2 handout, and we'll continue after that. How will you know that death has occurred? As a hospice volunteer, it's crucial to understand the signs that indicate death has occurred. For those of you that will be doing direct patient care, there's high probability that you may be present at the time of death. If not present, you'll certainly be around during those final days, those final hours towards someone's life, which means you may encounter some of these signs. These signs include the absence of breathing, no detectable pulse, pupils that are fixed, unresponsive to light. The body may become cool to the touch, the muscles relax, leading to a limp appearance. When you observe any of these signs, it's important to stay calm and simply notify the hospice care team as soon as possible. Remember, in hospice, death is not a medical emergency. It's a planned event. We know that this day is coming, so you do not need to panic. Simply remain calm. You never want to inform family or loved ones, hey, I think your loved one's gone. Simply say, I think it's time we call the hospice nurse. Leave it for the hospice nurse. She is professionally trained for these moments. She's the only person that can pronounce someone, and there are certain things that they're going to be looking for. They're going to be looking for the grief response from the family to make sure that there's no emergencies or interventions that need to take place in the immediate. So again, as a hospice volunteer, even if you are present at the time of death, remain calm. It's not a medical emergency. Never break that news to the family or loved ones. Simply say, I think it's time we call the hospice nurse. Just to reiterate, when death occurs, do not call 911. It is not a medical emergency. Simply call the hospice team. Okay? Calling 911 can bring unnecessary medical interventions that may disrupt the peace for the family and the loved ones at that time. They should just contact the hospice provider. They'll handle all necessary arrangements. Again, they're not going to be surprised by this. It's a planned event, and they'll provide support during this emotional time. All right, we've got time for a quick interactive exercise. We're going to walk through this one together. It's a little bit different than a journal exercise. Here's the scenario. Bob is a 73-year-old man who has been diagnosed with bone cancer. His family says he has not awakened in 2 days. They are nervous because of breathing pauses up to 30 seconds. So they've noticed pauses in breathing lasting as long as 30 seconds, and they feel they should make a call. The family should call 911 immediately. Number 2, this is apnea and a common sign that death is approaching. Call hospice. Number 3, no need to call anyone and suggest that the family increase Bob's medication. And the answer to this is going to be that this is known as apnea and a common sign that death is approaching. And the appropriate response, again, it's not a medical emergency, so we're going to call the hospice on-call line, which is usually going to be a nurse, or they'll connect you with a nurse, and they are going to go ahead from there and take whatever necessary steps they have already deemed according to the care plan. Let's take a moment and talk about the time of death and the volunteer. A hospice volunteer can play a crucial role in providing emotional, but also practical support to families during the time of death. And there are some ways a volunteer could assist. Okay, the first one would be emotional support. I want to encourage you to offer presence. Sometimes simply being there with someone can be comforting. Sitting with the family, offering a hand to hold if appropriate, simply being a quiet presence during such an emotional time is really important. It's important to let the family know that there's no need to rush the moment. It's not uncommon for people to feel like there's a lot to do in this moment and they should be busy. But again, this is something that has been anticipated, and it is perfectly acceptable, even encouraged, for them to just be present in the moment. They can just sit, reassure them. There's nothing that needs to be taken care of on their part. Simply call the hospice team and everything will be in motion, and they can simply be present in this moment. Listening and comforting, they can listen to them, process their emotions, provide a compassionate and non-judgmental ear. And then the reassurance, offer gentle reassurance. It's a natural part of life, and ensure that their loved one will be cared for with dignity. Another thing is just practical support. Offer to notify the hospice staff. Ask if there's anybody else on their behalf that they would like to be contacted. Help with any immediate needs. Practical things such as making phone calls, arranging for food or refreshments, helping to gather personal belongings. If appropriate and allowed, the family may want to bathe or dress the person before their loved one's body is removed. It's a perfectly appropriate thing to do. We call it a blessings bath before the funeral home takes over the care of the body. Oftentimes, this is something that is very therapeutic for a loved one or family member to do. Usually, these sort of things are decided on before the time of passing, but oftentimes their wishes and desires may change in that moment, and that's perfectly acceptable as well. And simply tidying up the space, again, is another great practical thing that a volunteer can offer in this time. Make sure that it's just an ensuring calm, respectful environment. Another way that they can offer support at the time of death is through a spiritual or ritual support. And this doesn't have to be a religious thing. Maybe there's a cultural practice. Some families have specific rituals or prayers that they perform at the time of death. And so perhaps you can help facilitate or support in these practices. Something like a lighting of a candle or playing music to set that environment is perfectly acceptable. It can offer a sense of calm during those final moments. Another great form of support for the volunteer at the time of death is bereavement support, assisting with an early grief response. It's important to remember that the time right after death is a critical moment in their grief journey. It seems like everything has been building to this moment, and there's going to be this temptation to rush into action. A volunteer can encourage them to be present to their grief, help them slow down. There is no need to rush. There is no emergency to attend to. Suggest that they take some deep, calming breaths. Invite them to step out of the room for a moment if they need to, or ask them if they would like you to step out so that they can be alone with their loved one. Again, just assisting and encouraging their early grief response goes a long way in what their bereavement journey is going to be like in the days, weeks, and months to come. You can be that comforting presence to the loved one. Okay, we've covered quite a bit here. Some of this can contain some challenging information. Discussions about death and dying, it's uncomfortable, brings up a lot of emotion. So we want to pause here. And we're going to ask, how are you feeling now? Sit with that question. What emotions does this bring up for you? Maybe you've lost someone in the past, and so this is bringing back some of those emotions. What are your thoughts about being present at the time of death? Is that something that you've thought about? Now that you've thought about some of the practicalities of it, are you still comfortable with that? These are all things to think on. Again, there's no right or wrong answers. You're not reporting these things. We're creating a space to pause, to be with the feelings and the thoughts that emerge. This is all part of being a good hospice volunteer. So please pause the video now, reflect on these questions. When you're ready, we will continue on. All right, this next section of the training is dedicated to understanding grief and loss. Here's a quote for us. You will lose someone you can't live without, and your heart will be badly broken. And the bad news is that you never completely get over the loss of your beloved. But this is also the good news. They live forever in your broken heart that doesn't seal back up, and you come through. It's like having a broken leg that never heals perfectly. It still hurts when the weather gets cold, but you learn to dance with the limp. So we're going to take a few minutes and understand the difference between grief, bereavement, and mourning. These are all words that are used, and they can be used interchangeably. It can get confusing, and so we really want to distinguish between the three of these, as they each have distinct meanings within hospice care. First one is this. It's grief. According to Merriam-Webster definition, it is a deep and poignant distress caused by or as if by bereavement. Okay? So an expanded definition of this would be it's the internal experience of loss. So grief is the internal state. It's what a person feels on the inside. Now, this can involve a complex range of emotions, including sadness, anger, confusion. For some people, even relief. It's not uncommon for a caregiver that's been giving care for a long time or watching their loved ones suffer through pain for a long time, for them to experience a sense of relief, and then with that can come guilt, and then it circles back to that anger and confusion and sadness. It's a whirlwind of complex emotions. So grief is a normal reaction to the loss of someone or something meaningful, and it can be experienced emotionally, physically, spiritually, and cognitively, but it is the internal experience of loss. Looking at the next one, bereavement, the Merriam-Webster definition is this. It's suffering the death of a loved one. So it's referring to the act of or the state of having lost someone close. So that expanded definition actually encompasses that. Bereavement refers to the state of having lost someone close. It is the period of time following a loss during which grief is felt and mourning occurs. Okay, so grief is the feeling. We'll talk about mourning in just a second. But bereavement is the period of time following a loss. It's often accompanied by certain rituals or customs that are culture or faith-based. And the third one is mourning, okay? The Merriam-Webster definition for this is an outward sign. So an example of that might be black clothes or an armband of grief for a person's death. Okay, so mourning is the outward expression of grief. And again, they give some examples there: wearing black, attending a funeral, other cultural practices. It's the process through which people express and come to terms with their grief. So grief is that inner experience, it's what the person is feeling, and mourning is that outward expression of that. Mourning is the process through which people express and come to terms with grief. Grief is eternal. Mourning is how we show our grief to others. And bereavement is that period of time where someone is experiencing grief, reflecting their mourning practices. They're in bereavement. Now that we've got an understanding of some of those terms, being grief and mourning and bereavement, it's important that we understand the different types of grief. There are different types of grief, and when we're following a family or a loved one after the passing of their loved one, we want to make sure that they are well supported to navigate their grief. Okay, so the first thing is anticipatory grief. Now, this occurs before a loss even happens, often when a loved one is terminally ill. Patients and families may begin to mourn their impending loss. And it's not uncommon as well in the early stages as roles begin to change, relational roles begin to change. Maybe a parent now becomes someone that you are providing care for. And so people will begin to grieve maybe even the changing of those roles. There's a lot that goes into anticipatory grief, but just as the term says, it's anticipating, it's beforehand, completely normal. But the first type of grief that we encompass is usually an anticipatory grief. And then we've got normal grief. When you lose a loved one, you're going to experience grief. And so what we look for is what we would call normal grief. Normal grief is the natural response to loss. It involves emotions like sadness, anger, guilt, and relief. These feelings can fluctuate, and they generally lessen over time, though they may still arise months or years later. There is no roadmap to grief. There is no timeline. Most people can continue in functioning in their daily lives with the intensity of grief gradually decreasing. So that's what we look for with normal grief. It's hopefully over time, it's gradually decreasing. Most intense, obviously, at first. There'll be pockets of it re-emerging and being just as intense. But over time, people can continue to function in their daily lives, all right? And so what we're really monitoring for is what we would call complicated grief. That's what we're looking for, is complicated grief. And this is one of the reasons why it's so important that at the time of death, if a hospice volunteer is there for it, that if they have an inclination that the patient has passed, the first thing that they're going to say is, I think it's time we call the hospice team, because when the nurse arrives, she's going to be looking for signs of complicated grief. They've been specifically trained to see if there's any abnormal grief reactions. One of the things we're looking for is complicated grief, and it is abnormal grief that is prolonged and intense, and it does interfere with normal functioning. Okay, so it could be persistent longing, inability to accept the loss, extreme avoidance. There could be withdrawal, difficulty with daily activities, excessive focus on the deceased. This is when, if there's a pattern of addiction or suicidal ideations or things like that, these are all things that we are looking for, and there may need to be some elevated interventions for those loved ones. We want to make sure that we walk with them during this difficult time. There's nothing wrong with complicated grief, okay? People are going to experience it. Not everyone grieves the same, but we want to make sure that they are well supported in getting the resources that they need, as professional help may be needed at this time. So in short, if we were to summarize it, there's anticipatory grief, there's normal grief, and there's complicated grief. That's an oversimplified overlook of grief, but it's important to have those three in your mind as a hospice volunteer. Other types of grief that we'll just briefly hit on, there's cumulative grief. It's experiences after multiple losses in a short period of time. This can compound emotional stress, makes grieving more difficult. The likelihood of complicated grief, that type of grief that we really want to monitor for, is more likely in these situations. So maybe it's the loss of a loved one. Sometimes, though, it could be something like a divorce or the ending of a relationship or a big move, or a medical diagnosis that they received themselves and then they also lost the loved one. Anything that is compounding and layering their grief, we would call that cumulative grief. Then there's also delayed grief. Again, this is something that we're going to look for immediately. This could lead to more complicated grief, but it's a grief that is postponed, not immediately felt after a loss. Someone may just numb out. They may turn to coping mechanisms. They may go to good things like practical responsibilities. And so at first they're not living in it. There's sort of a sense of numbing, and it could emerge much later. It could be triggered by another event. The reason why we look for this is because oftentimes people will move on and think that that person is okay, when in reality they're not okay. They're experiencing delayed grief, and when that surfaces, if they don't have the resources there, that could be problematic. And then there's masked grief. It occurs when a person doesn't recognize their grief and it manifests in other ways. Physical symptoms, erratic behavior, addiction issues. Masked grief is something to look for as well. Now, this is where the Kubler-Ross model of the 5 stages of grief often comes into play. Again, they are often referenced when it comes to grief. It is worth noting again that when Kubler-Ross wrote on death and dying and presented these 5 stages, they were meant for someone that had been diagnosed with a terminal illness, so they're still living and they're trying to process their own mortality, and had less to do with those that were processing the death of a loved one. Nevertheless, they are helpful to review. It's also worth noting that this is not a easy spectrum that people move through. They don't always move from denial to anger to bargaining. There's a lot of overlap, and oftentimes they'll move from one stage to the other and then move backwards. It's not perfect symmetry in how someone will move through these stages, but they are denial. The initial reaction, usually they don't believe it. There's sort of a defense mechanisms that helps to soften that shock for the psyche. There's anger as it sets in. There's frustration, restlessness. They're mad at others. There's bargaining. People may try to regain control by thinking that they could prevent it somehow, or by making deals in their mind. If they have an idea of a higher power, they'll also try to do that. Depression, deep sadness, longing, and then acceptance. Hopefully over time, the individual begins to accept the reality. Okay, the role of the hospice volunteer in assisting with grief. 3 things that we want to hit on. First off, let's just say this. As a hospice volunteer, you are not in the role or capacity as a therapist or a counselor. We leave that for those that are in that position to do. However, as a hospice volunteer, even though your role is not to fix grief or to provide counseling, you can be present, you can be supportive, you can offer compassion, a listening ear, and give comfort. And so here are 3 ways that you can do that. Number 1, active listening and empathy. It is one of the most valuable things you can offer, is simply be there to listen. Families, patients, they need someone to listen without judgment. So don't be quick to give advice. Don't use your own personal stories unless you think it's absolutely appropriate. Don't try to change how they feel. The goal is not to cheer them up. It's simply to be fully present during their conversations, to validate their feelings, to let them know that it's normal. Things like, this must be really hard, or I can't imagine what you're going through. Show empathy by acknowledging the pain and sadness that they may be feeling. Empathy is about trying to understand their emotions and letting them know it's okay to feel whatever it is that they're feeling. So don't be quick to try to make them feel a different emotion. That's not the end goal. Just simply be there, listen to what it is they have to say. Provide space for comfort. Grief can manifest in many ways. It can be from talking to complete silence, from crying to laughter. Allow patients, family members, the space to express their grief in whatever way is appropriate in that moment. Avoid rushing them through their emotions. Sometimes your presence is simply all that's needed. And so just provide that space. Don't feel like you have to fill the time or moments of silence with words. Just simply be present, sitting in silence with someone, offering a comforting hand if it's appropriate. Reading aloud from a book or a poem can make a huge difference. Your simple presence is a big deal. And thirdly, just make sure that you respect their cultural practices. Be sensitive to the morning rituals or customs of different cultures and religions. Hopefully, by this stage in their end of life journey, you've gotten to know the family and the individuals well enough where you've got kind of an idea of some of their cultural preferences. Allow families the space to mourn in ways that are meaningful to them, and look for ways to honor those traditions. Okay, we've got another video resource for you as we get ready to close out Module 2. This is on the 5 stages of grief. So again, it's that Kubler-Ross 5 stages of grief we talked briefly about. This kind of illustrates it. Hopefully we'll lock it in. Once again, it's an important component to remember within hospice. To access this resource, please use the link found in that Module 2 handout. It's not a super long video, but it is worth watching. Please use that link and we'll continue here when you're done. Okay, we have reached the completion of Module 2. We've talked about death and dying and grief and bereavement, the stages of death, fears of death, the hospice volunteer's role at the time of death, what does bereavement and grief and mourning all mean, and what are ways that we can contribute as a hospice volunteer at the end of someone's life to both them and their loved ones. We ask at this time that you do complete the Module 2 quiz. You can access that quiz by using the link found in your Module 2 handout. It is not a pass or fail sort of thing. It simply is reviewing some of the more important concepts that we have covered during Module 2. So to access it, please use the link found in your Module 2 handout.